Good health and welcome to today's edition of the Wellness Watch. I'm your host, Dr. Mike Lenore. Asthma is always a changing disease. It seems like the more we know, the less we know. We're starting to understand and appreciate that any episode that an asthma patient has during a season called an exacerbation is a detriment to the overall health and difficulty in managing the problem. And now we're starting to look at new ways in which we can deal with these acute attacks to reduce exacerbations. And so I'd like to now introduce Dr. Desmond Haynes. He's going to talk about rescue therapy to help prevent these exacerbations. So I want to explain to you why they're so detrimental to the patient with asthma and what medicine is trying to do to reduce them.
My name is Dr. Desmond Haynes. I'm a pulmonary and critical care physician at the University of Mississippi Medical Center. Thank you for joining us for this presentation entitled Reframing Rescue Therapy to Help Prevent Asthma Exacerbations. Please note, this presentation does not qualify for any form of continuing education credit. The objectives for this presentation include the following. Recognize the impact of asthma exacerbations on the burden of disease for patients with asthma in the United States. Gain an understanding of the role of variable airway inflammation in asthma exacerbations and the consequent burden of systemic corticosteroid exposures. And finally, examine data on a rescue therapy option to help prevent asthma exacerbations. Let's start by taking a look at how exacerbations impact the burden of asthma in the United States. In 2020, approximately 25.3 million people in the United States were living with asthma, with over 10 million asthma attacks in 2020 alone. Data from the Centers for Disease Control and Prevention in 2019 reported an estimated 1.8 million emergency department visits and 170,000 annual hospitalizations due to asthma. Additionally, a retrospective study which evaluated claims data in over 435,000 patients from 2012 to 2017 showed that nearly 2/3 of patients 12 years of age or older with persistent asthma received oral corticosteroids during the follow-up period. Taken together, these data show that asthma exacerbations contribute significantly to the morbidity of asthma. With a significantly improved understanding of the pathophysiology of asthma and a number of therapies developed in recent years, one might have expected a greater improvement in these numbers. Unfortunately, as you can see here, decades of scientific innovations have not resulted in the exacerbation reduction we might have expected. As the U.S. population has grown, so too has the prevalence of asthma. You can see that the estimated number of patients recognized as having asthma has more than doubled from 1990 to 2020. While hospitalizations have decreased, as shown with the blue line, emergency department visits, as shown with the red line, have not changed significantly. How can we better understand why severe asthma exacerbations are still occurring at such a high level? Major scientific discoveries have been made surrounding asthma, generating multiple updates by the Global Initiative for Asthma, or GINA, and the National Asthma Education and Prevention Program, or NAEPP. Yet, the burden of asthma persists. Perhaps we need to go back to the basics and take a closer look. Airway inflammation is central to asthma symptoms and exacerbations. In patients with asthma, we can see tightened airway smooth muscles, airway wall swelling, infiltration with inflammatory cells, mucus gland hypersecretion, and a thickened subepithelial basement membrane with fibrosis. These changes can result in airway luminal narrowing and symptoms. And importantly, the inflammation and symptoms of asthma vary over time and intensity and can lead to asthma exacerbations. Patients with asthma experience episodic exposures to allergic and non-allergic triggers that can lead to variability in inflammation and symptoms. Treatment with anti-inflammatory maintenance therapies is intended to address baseline levels of inflammation as shown by the dashed line in the illustration. However, maintenance therapy may not always be able to address changes in inflammation. Rising inflammation may cause airway narrowing, decreased lung function, and increased symptoms, and can lead to an exacerbation. In fact, the way in which patients use SABA rescue and maintenance therapy in the real world may not fully address fluctuating inflammation or eliminate the risk of exacerbations. In this medical and pharmacy claims data analysis of over 135,000 patients, 12 years of age and above, with commercial or Medicare Advantage insurance, you can see there is a heterogeneity in asthma control as measured by SABA fields. Remember, there are 200 inhalations or 100 doses in each canister of SABA. Thus, over a 1-year period, if a patient used all these inhalations, the average SABA usage would be 2 doses or less per week, a sign of well-controlled asthma, which was observed in about a quarter of these patients. And if a patient used 2 to 3 canisters of SABA in a year, this would equate to more than twice a week dosing, but not daily, thus indicating not well-controlled asthma, as you can see here in about half of these patients. A fourth fill or more would provide enough SABA doses for daily use over a 52-week period, suggesting very poorly controlled asthma, as observed in about a quarter of these patients. It's not surprising that patients with worse symptom control would adhere to their maintenance therapy more, as assessed by their medication possession ratio, or MPR, over the 1-year observation period following a SABA fill. With increasing SABA fills, MPR increased from 53% to 66%, and this is actually quite good relative to what is reported in the literature. Nonetheless, regardless of the level of control or adherence to maintenance therapy, about 50% of patients experienced 1 or more annual severe asthma exacerbations. What about those patients who have good control and high adherence to their maintenance therapies? What is their risk for exacerbations? Let's look at additional medical and pharmacy claims data from over 350,000 people, 12 years of age and above, with commercial, Medicaid, or employer-sponsored Medicare insurance coverage. Of the overall study population, nearly 31% were considered to have well-controlled asthma, as defined by filling only 1 SABA in a year. Approximately 13% had high adherence based on maintenance medication fills over a 1-year time period and a standard of maintenance medication possession ratio of greater than or equal to 80%. The bar graph shows the 4% of patients in this analysis who were considered to have both good control and high adherence. Approximately 36 to 54% of these patients experienced 1 or more severe exacerbations annually, regardless of the level or type of maintenance therapy. Thus, patients with persistent asthma are at risk of exacerbations irrespective of asthma control, maintenance adherence, or disease severity. While treatment of exacerbations with systemic corticosteroids is often necessary and effective, observational data have suggested that standard bursts of systemic corticosteroids may result in a cumulative steroid burden impacting future health. Shown here is data from an observational study by Price et al. Demonstrating the potential risk of developing adverse health conditions due to varying levels of cumulative SCS exposure. The risk of developing conditions such as diabetes, anxiety, and depression as a result of systemic corticosteroid use increased as exposure to systemic corticosteroids accumulated over a lifetime. Shown here, statistical significance was evident when cumulative lifetime systemic corticosteroid exposure crossed a threshold of 500 milligrams to just under 1,000 milligrams. A greater risk occurred and more adverse conditions emerged, such as osteoporosis and cardiovascular disease, between 1,000 milligrams and 2,500 milligrams of cumulative systemic corticosteroid exposure. In a separate retrospective cohort study and self-controlled case series, it was observed that within 30 days of oral corticosteroid initiation, the incidence of adverse events such as sepsis, venous thromboembolism, and fracture approximately doubled. Thus, treatment of exacerbations with systemic corticosteroids contributes to the burden of disease that may affect future health. You might be wondering how easily reaching the 500 or 1,000 milligram levels happen in clinical practice. Based on recommendations from GINA and the NAEPP Expert Panel Report 3 from 2007, where a range of SCS dosing options are provided, even with one burst, a patient could be exposed to or even exceed that 500 milligram threshold, as shown starting with the yellow in the bottom right of the first column. With the second burst, the majority of patients would reach exposure levels of at least 500 milligrams, with some even reaching at least 1,000 milligrams, as shown in the red at the bottom right of the second column. And with the third burst, most patients would have reached a cumulative threshold where the risk of adverse health condition significantly increased. Keep in mind, this is illustrative of the use of SCS for asthma and does not include other cumulative exposures patients may receive for the treatment of other conditions. In real-world use, it can be quite difficult for clinicians to track cumulative lifetime SCS exposures, as electronic medical records are often incomplete. This begs the question, is there a window of opportunity to interrupt an impending exacerbation and avoid the need for systemic corticosteroids? Findings from the FACET study presented on this slide can help answer that question. The FACET study examined the patterns of change in peak expiratory flow rate, symptoms, and rescue use in the days preceding 425 exacerbation events. As shown on the graph, circled in red, it was observed that the peak fell while symptoms and the use of bronchodilators increased in the 10 days before the onset of an exacerbation. And note that rising airway inflammation can result in decreased lung function, increased symptoms, and increased rescue bronchodilator use. Therefore, interrupting a rise of inflammation may prevent the occurrence of an exacerbation and avoid the need for systemic corticosteroids. Treating symptoms and inflammation concomitantly with rescue or reliever therapy that includes both an ICS plus a fast-acting bronchodilator is supported by the latest recommendations from GINA and NAEPP. As a reminder, SABAs and formoterol are considered fast-acting bronchodilators. In fact, NAEPP guidance from 2020 incorporates this concept at steps 2, 3, and 4 as preferred therapy, with concomitant ICS plus SABA recommended at step 2, and ICS plus formoterol maintenance and rescue at steps 3 and 4. GINA 2023 also supports this approach with ICS formoterol as a preferred reliever across all treatment steps in track 1. In GINA, SABA alone as reliever therapy is no longer recommended. Also, GINA states, the risk of severe exacerbations and mortality increases incrementally with higher SABA use independent of the treatment step. It is important to remember that the use of ICS formoterol is not approved in the United States for concomitant maintenance and rescue therapy or for as-needed rescue. The recommendations for ICS formoterol are based on clinical data evaluating the use of ICS formoterol formulations and strengths not approved and not available in the United States. GINA 2023 includes recommendations for the concomitant use of SABA and ICS in its track 2 controller and reliever treatment steps for patients of all disease severities. As can be seen, the reliever options recommended in this track are as needed SABA or as needed ICS SABA. Gina also states that before considering a reliever regimen with a SABA, check if the patient is likely to adhere to daily controller treatment. Gina emphasizes a personalized asthma management plan involving a continual cycle of assessment, adjustment of treatment, and review. The plan should be developed according to an individual patient's needs in order to achieve the goals of asthma treatment. Let's review what we have discussed so far. The impact of exacerbations on the burden of asthma in the United States is significant, despite decades of scientific discoveries and updated management recommendations. Variable airway inflammation plays a major role in the occurrence of exacerbations, while the treatment of exacerbations with systemic corticosteroids can increase the risk of long-term adverse health conditions. And a window of opportunity may exist to help prevent a severe exacerbation if symptoms and inflammation are treated concomitantly, as expert opinion reports suggest. Now, we will transition to a review of the clinical data for AirSupra, a fixed-dose combination medication where each inhalation consists of 90 micrograms of albuterol and 80 micrograms of budesonide. AirSupra is a therapy that was designed to shift the treatment paradigm to help address the problem of exacerbations for patients with asthma. Please see the full prescribing information, including patient information for AirSupra, available at www.airsupra.com or at www.azpicentral.com. AirSupra was approved by the FDA in January of 2023 and is a combination of albuterol, a short-acting beta-2 adrenergic agonist, and budesonide, an inhaled corticosteroid. AirSupra is indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older. The recommended dose of AirSupra is 180 micrograms of albuterol and 160 micrograms of budesonide administered as 2 inhalations of AirSupra. Patients are instructed not to exceed more than 6 doses or 12 inhalations in a 24-hour period. Before reviewing the clinical data, let's focus on some select important safety information. Contraindications to using AirSupra include hypersensitivity to albuterol, budesonide, or any of the excipients. Deterioration of asthma can occur acutely or chronically. So if a patient continues to experience symptoms after using AirSupra or requires more doses of AirSupra than usual, it may be a marker of asthma destabilization. AirSupra can produce paradoxical bronchospasm, which may be life-threatening. If paradoxical bronchospasm occurs, AirSupra should be discontinued immediately and alternative therapy instituted. When associated with inhaled formulations, it frequently occurs with the first use of a new canister. AirSupra, like other drugs containing beta-2 adrenergic agonists, can produce clinically significant cardiovascular effects in some patients and may need to be discontinued. AirSupra should be used with caution in patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Please see additional safety information and the full prescribing information, including patient information, at the end of this presentation. Let's now review key AirSupra data from the Mandala study, a pivotal phase 3 clinical trial used to support the approval of as-needed therapy with a combination of albuterol and budesonide. The Mandala study was designed to evaluate the efficacy and safety of albuterol in combination with budesonide given as needed, albuterol over budesonide 180 over 160 micrograms or 180 over 80 micrograms, with each dose consisting of 2 actuations of 90 over 80 micrograms or 90 over 40 micrograms, respectively, versus as needed albuterol 180 micrograms, each dose consisting of 2 actuations of 90 micrograms as rescue therapy in patients with uncontrolled moderate to severe asthma. This event-driven study enrolled symptomatic patients who had experienced at least one severe asthma exacerbation in the previous year and were receiving maintenance therapy to treat moderate to severe asthma, as defined by GINA, for greater than or equal to 3 months prior to study entry. Randomized patients continued their background maintenance therapy throughout the trial. It is important to note that while patients 12 to 17 years of age were included in Mandala, AirSuper is not approved in this age group. Therefore, efficacy results are only presented for adults 18 years of age or older. Since albuterol budesonide 180 over 80 micrograms is not an approved dose, this presentation will not include results for this arm of the study. In addition, select inclusion criteria for the Mandala trial were as follows: symptomatic patients with moderate to severe asthma, a physician diagnosis of asthma documented for at least 1 year, and were receiving one of the following scheduled asthma maintenance therapies for greater than or equal to 3 months, with stable dosing for 4 or more weeks prior to screening. Medium to high dose ICS or low to high dose ICS in combination with LABA with or without additional controller, a leukotriene receptor antagonist, a long-acting muscarinic antagonist, or xanthines. Pre-bronchodilator FEV1 of greater than or equal to 40 to less than 90% predicted normal and confirmed reversibility to albuterol were also inclusion criteria, along with an ACQ-5 score greater than or equal to 1.5 at visit 2, indicating uncontrolled asthma. Key exclusion criteria included chronic obstructive pulmonary disease or other significant lung disease, systemic corticosteroid use within 6 weeks prior to screening, chronic oral corticosteroid use greater than or equal to 3 weeks within 3 months prior to screening, and biologic treatment within 3 months or 5 half-lives of screening. As you can see in the adult efficacy population, 2,940 patients, baseline demographics for the 979 patients in the albuterol budesonide 180 over 160 micrograms arm were similar to the 980 patients in the albuterol 180 micrograms arm of the study. Overall, the mean age was 52 years, and of patients included, 66% were female, 82% were white, and 25% were of Hispanic or Latino ethnicity. Baseline disease characteristics were also comparable across the treatment arms. The mean pre-bronchodilator forced expiratory volume in 1 second was about 63% of predicted normal, with the mean reversibility of about 28%. With respect to the ICS maintenance-based therapies, roughly 30% of patients were receiving low-dose ICS long-acting beta-2 agonists, LABA, or medium-dose ICS. 40% were receiving medium-dose ICS LABA or high-dose ICS, and 28% were receiving high-dose ICS LABA. About 80% of patients had one exacerbation in the 12 months prior to screening, whereas about 20% had more than one severe exacerbation. Additionally, the mean ACQ-5 score was 2.6, indicative of uncontrolled asthma, and the mean AQ-LQ plus 12 score was 4.6 across treatment groups. Now, turning to the results of the Mandala study for the participants who were 18 years of age and older. The primary endpoint was the time to first severe asthma exacerbation, with severe exacerbation defined as an asthma clinical worsening leading to one of the following: 3-day course of systemic corticosteroids or corresponding single injectable dose, emergency room or urgent care visit due to asthma that requires systemic corticosteroids, or hospitalization for at least 24 hours due to asthma. Note the divergence between the albuterol budesonide 180 over 160 micrograms and albuterol arms on the Kaplan-Meier curve shown here. The data shown are for patients 18 years of age and older from the pre-planned on-treatment efficacy analysis, collected while patients were on randomized treatment prior to treatment discontinuation or change in maintenance therapy. Data was censored at the time of discontinuation or change in therapy. Albuterol budesonide 180 over 160 micrograms significantly reduced the risk of severe asthma exacerbations in a time to first severe exacerbation analysis by 28%, compared to albuterol 180 micrograms with a hazard ratio of 0.72, a 95% confidence interval of 0.6 to 0.86, and with a statistically significant p-value of less than 0.001. There were also significant differences in the key secondary endpoints of the study. The annualized severe exacerbation rate was reduced by 24% for those receiving albuterol budesonide 180 over 160 micrograms compared to albuterol 180 micrograms. The rate ratio was 0.76 with 95% confidence interval of 0.62 to 0.93 and a statistically significant p-value of 0.008. Also note that the mean total annualized systemic corticosteroid exposure was also significantly reduced by 31.5%, equivalent to a mean difference of 40 milligrams per patient. Now that we have reviewed efficacy results, let's look at a summary of adverse reactions reported in greater than or equal to 1% of the overall study population. For albuterol budesonide 180 over 160 micrograms, headache was 4.3%, oral candidiasis was 1.3%, and cough was 1%. As you can see, the safety profile of albuterol budesonide was similar to albuterol irrespective of background inhaled corticosteroid dose. Just a reminder that the adverse reactions shown for albuterol budesonide 180 over 160 micrograms and albuterol 180 micrograms are for the patients 12 years or older. AirSupra is not approved for patients 12 to 17 years of age. AirSupra is indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older. To complete the description of AirSupra, the next 3 slides provide additional important safety information. Patients should not exceed the recommended dose. Clinically significant cardiovascular effects and fatalities have been reported in association with the excess use of inhaled sympathomimetic drugs. Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol sulfate and budesonide, components of AirSupra. Discontinue AirSupra if the reactions shown on the slide occur. AirSupra should be used with caution in patients with certain coexisting conditions, such as convulsive disorders, hyperthyroidism, or diabetes mellitus, and in patients who are unusually responsive to sympathomimetic amines. Significant hypokalemia may occur in some patients from use of beta-adrenergic agonists, and possible immunosuppression and potential worsening of infections from the use of inhaled corticosteroids, ICS, could occur. Use with caution. A more serious or fatal course of chickenpox or measles can occur in susceptible patients. Additional important safety information includes oropharyngeal candidiasis has occurred in patients treated with ICS agents. Advise patients to rinse their mouth with water if available. Hypercorticism and adrenal suppression may occur with very high doses in susceptible individuals. Reduction in bone mineral density has been observed, and glaucoma and cataracts have been reported with long-term administration of ICS. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity when administered to pediatric patients. However, note that safety and effectiveness of AirSupra have not been established in pediatric patients, and AirSupra is not indicated for use in this population. Further important safety information includes the most common adverse reactions reported for AirSupra with an incidence of greater than or equal to 1% were headache, oral candidiasis, cough, and dysphonia. AirSupra should be administered with caution to patients being treated with strong cytochrome P450 3A4 inhibitors, short-acting bronchodilators, beta blockers, diuretics, or non-potassium-sparing diuretics, digoxin, monoamine oxidase inhibitors, or tricyclic antidepressants. Use AirSupra with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. Please see the full prescribing information, including patient information for AirSupra, available at www.airsupra.com or at www.azpicentral.com. As we come to a close, let's review the key conclusions from the Mandala trial we have discussed and recall what we have learned about the burden of exacerbations from the first part of our discussion today. To summarize, AirSupra is the first and only rescue medication approved in the U.S. for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma, 18 years of age and older. In the Mandala study, AirSupra significantly reduced the risk of severe exacerbations by 28% compared to albuterol. AirSupra also significantly decreased the annualized rate of severe exacerbations by 24% and annualized systemic corticosteroid dose by 31.5% compared to albuterol. The most common adverse reactions are headache, oral candidiasis, cough, and dysphonia. Given the significant burden of exacerbations and systemic corticosteroid exposure in the U.S., AirSupra offers the ability to treat symptoms and airway inflammation concomitantly to help reduce the burden of disease for patients with asthma. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any comments about this presentation, please contact AstraZeneca at 1-800-236-9933. For medical information, request, and access to other AstraZeneca resources, please visit azmedical.com. You are encouraged to report negative side effects of AstraZeneca prescription drugs by calling 1-800-236-9933. If you prefer to report these to the FDA, call 1-800-FDA-1088. Thank you for your time and attention. I invite you to take a moment to complete this post-evaluation survey. Please open your browser in a new tab and navigate to the address provided on the screen. Or alternatively, point your cell phone's camera at the QR code that you now see to connect to the survey. For each question, select the corresponding option that reflects your choice. The references included in this presentation are available here and on the next two slides for your review.
Well, thank you, Dr. Haynes. I've been an allergist specialist for 40 years, and our understanding and our ability to manage the disease has improved fairly dramatically. But it's always interesting and exciting when new data comes along that results in better management and better treatment. Before I have some more specific questions, can you explain to our doctors and the people listening what exactly is happening in the lung when you have an exacerbation?
Absolutely. Thank you so much, Dr. Lenore. I appreciate you. When our patients are having exacerbations, a couple of things are occurring. There's an increase in inflammation and also bronchoconstriction. So there, inflammatory markers, a lot of inflammation is going on in these exacerbations, and the bronchoconstriction is going on in the airways.
Yeah, so it's almost like when you have an injury to the knee or inflammation anywhere else, that it may be a little bit of damage done each time, and so you definitely want to avoid those.
Yeah.
Most of us who have been treating asthma, going to the meetings, were under the impression that the combination of long-acting beta agonist and inhaled corticosteroids had already been recommended in this country for use for exacerbations, but not so.
So you're referring really to SMART therapy, which is recommended in some of the guidelines. Those were approved. Those guidelines were made based on recommendations that were not with medications that's not available in the U.S. and in different formulations that's available in the U.S. So there is that recommendation for SMART therapy, but there was no currently approved therapy in the United States for that therapy, even though it was in the guidelines. It was based on some of those international studies.
Well, now that you've got this drug out there, this medication, you think we'll finally get some proof that PRN use of combinations of beta agents and inhaled corticosteroids really make a difference?
Oh, yeah. So if you think about the data from AirSupra, I knew I went through it a little quickly. If you look at the data from AirSupra making a difference, a couple of different things we can look at, right? You're looking at that 24% decrease in severe annual exacerbation rate with those patients. I like that Gina has put in these 2023 guidelines that we need to assess and review our patients, making sure that for control, making sure that we are looking at exacerbation history in that control, because one exacerbation we know predisposes patients to another exacerbation. So they will want to make sure that we're looking at it from a risk impairment domain type way to look at these patients. So are they having exacerbations when we're talking about assessing their control?
We can't nowadays talk about asthma without talking about some biomarker. There's so many biomarkers, I'm thinking maybe they'll name one after me at some point in time. But do you think that your studies and your experience with AirSupra will finally identify some of these biomarkers to explain how this combination works for exacerbations?
I think so. So we have in vitro data already, data from in vitro studies saying what do inhaled steroids do to help, beta 2 agonists or beta 2 bronchodilators. So there's some what we call genomic and non-genomic effects. So some that occur pretty quickly within minutes, excuse me, which using the inhaled steroid with those studies increases beta 2 agonist bronchodilation. And then there's some others that may occur with 4 to 24 hours where there was an increase in beta 2 gene transcription. And so we have other studies that are looking at this. And so we'll get some studies looking at albuterol budesonide compared to albuterol only and get some more in vivo results to better explain these interactions for ICS and SABA.
Well, I'm surprised by some of the studies that demonstrate the downside for using corticosteroids even in such short burst. Is there really any evidence that exposure to this amount of inhaled corticosteroids is really detrimental?
So the inhaled corticosteroids, the good news is we have some data that looked at if patients were to use the albuterol budesonide on top of their maintenance therapy, right, which most of them would include an inhaled steroid, that they would not exceed recommended doses. But on top of that, we actually have some ongoing studies right now. AstraZeneca has some ongoing studies looking specifically at that. And you'll be looking at data from Mandala comparing the actual ICS exposure of those patients, including the track maintenance ICS dose they were on, when you add that as needed albuterol budesonide to it. So we'll be able to see the total ICS exposure for all the patients in the studies, and that data will be forthcoming also.
Whenever you have a new medicine that's introduced for asthma, certainly there's a big push to use the biologics. I always ask my patients whenever I'm about to change a medicine, did you take the medicine before that? Why wouldn't we just, if we got a patient who is on some of these maintenance medicines, just bump up the maintenance medicine?
Oh, I think that's a great question. I'm like you too, Dr. Lenore. When I'm in clinic, you've been doing this a long time, and patients don't always use the medications when we're talking about it. So there again, that goes back to that assessment again for their level of control. But the other thing, I think when we use the word control, that's where a little nuance comes into place. We say control because there's data that patients can say they've been well controlled. Physicians say patients are well controlled. And then even the ACT score says patients are well controlled. But none of those, even though the physicians had access to the record to look in exacerbations, none of those really took exacerbations into assessment of that control. So if we say they're controlled, are they really? If they've had a history of exacerbation, even one will lead to another. So when we say they're controlled, we want to, yes, make sure they're taking their medication. Yes, make sure they're using it correctly, but also really get that exacerbation history, because even on maintenance therapy, there are fluctuations in inflammation that can lead to an exacerbation for our patients.
And we know that the manifestation, the symptoms of asthma are preceded by an awful lot of inflammation prior to that.
Yes.
Now, to digress a little bit, I can say, I've done all kinds of studies, and we validated the ACT test. I've seen spirometry and certainly nitrous oxide testing, but albuterol usage to me tells me more about control than anything else.
Mm-hmm.
Now, in this day and age, what about the cost of the medication? Is it savings?
So, if you look at data, there's some data from the PREPARE study when you talked about this, looked at using ICS and SABA in separate containers in two groups actually that are very important that have high rates of mortality in asthma. They looked at it in Black and Latinx adults and said, what happened if we use this ICS and SABA? And these were in separate devices. And it was significant, right? It showed fewer lost days of work and school, and improvement in their ACT score when they were using these.
The reigning philosophy was that we would not move in this direction, but that we would move in the direction of just either fiddling with or increasing the LABA in conjunction with the inhaled corticosteroids. I go back to the days when salmeterol was considered a relatively dangerous drug by some very flawed studies. And then all of the stuff that went in to make certain that these long-acting beta agonists were safe in certain ethnic populations. Yeah. Why didn't you go that route? Instead of using albuterol, why didn't you jump into the formoterol bandwagon?
So if you think about that, so some patients, right, are on inhaled steroids. So that would kind of be the MART therapy as opposed to SMART therapy. Not all our patients with asthma have formoterol in their maintenance regimen. And so if we added formoterol with the ICS to some regimens that had a different LABA in it, it really wouldn't be an option for those patients.
All right, now I'm one of those patients who has a bit of an asthma problem, and I tend to use albuterol. Mm-hmm. And I've avoided, obviously, some of the steroids because, you see, I don't have much of a voice as it is. It's been called a Harry Belafonte like voice without the good looks or the ability to sing a single note. But do you recommend that I switch from using pure albuterol to using Air Supra?
So, we're not making a specific recommendation, but I want to make a couple of points that we go back to, again, the assessment and reviewing, and again, that level of control. Have there been exacerbations? We also want to talk about, since you were talking about the hoarseness or issues that you have with some inhaled steroids or that as risk with inhaled steroids, if you look at the PI for the prescribing information and the patient information, then you would see that it is recommended to rinse, right, if water was available, and not to swallow Air Supra. And the good news is the data from the Air Supra from Mandala studies showed that the incidence of oropharyngeal candidiasis, which is usually what leads to our dysphonia, the incidence of that was very similar across the treatment arms, whether you were looking at the albuterol budesonide group, the Air Supra group, compared to the albuterol alone group.
All right, and one final question. When can I get my hands on Air Supra? Is it already being distributed?
That is a great question, Dr. Lenore. I cannot answer that. I can tell you it was approved by the FDA early in the year, right? And I know the company is doing their due diligence with making sure that, that it's affordable for people and that it's available and all those things. Personally, this is not me speaking for the company on this. I'm going to give my personal opinion. Personally, I think it'll be available for us, hopefully, the latter part of this year is what I'm hoping.
Well, Dr. Damon Haynes, thank you once again for taking the time to talk to our physician audience and other people who are listening. I think it's always good to have, when new medications are introduced, to have a professional explain to us the advantages and disadvantages instead of getting the information from a booth or from a passerby. So we'd like to thank you for informing us on the management and the assessment of asthma, the importance of exacerbations, and we know that people will benefit from your information. So I'd like to thank those of us who helped put this together, certainly Mr. John Bucksey and Mr. Ellis Dean, who is forever on the front lines of the information front. But most of all, I'd like to thank people who joined us. And remember, as we always say, when we conclude this program, health is your biggest asset, so protect it.